Good evening, ladies and gentlemen who have joined us via multiple social media platforms, Facebook, YouTube, Twitter, and the Dr. Fundi website. My name is Dr. Fundi Lenyati, and today we are tackling a topic that is of interest to many people in the social media space. We are going to discuss the project that was launched by the Eastern Cape Department of Health, where they launched a motorbike ambulance project. Since that launch, that happened late last week, there has been a lot of division in the nation about, the merits of the project, whether it was money well spent, and people are asking more questions. And today I've got a special guest, Dr. Livuyo Bayeni, who comes from the office of the MEC of Health in the Eastern Cape. Dr. Livuyo Bayeni holds an MPCHP from Medunsa, now called, okay, it's got a new name now. But anyway, he is a graduate of Medunsa. He also has a MBA from Nelson Mandela University. He is the technical advisor to the current MEC of Health. He was seconded there by the HOD because he has grown a reputation as Dr. Fix-It. So he has helped the department to deal with the issues of the circumcision program in the Eastern Cape. He has dealt with the issue of the Tower Psychiatric Hospital where there were problems. And he's also dealt with some of the issues at the Livingstone Tertiary Hospital. So he's the right person to help us to actually understand and maybe fix what I see as some miscommunication that took place last week. So Dr. Bayeni, welcome to the Dr. Fundi platform.
Let me take this opportunity and thank you for welcoming me and inviting me on the program. Also would like to also thank and welcome your viewers to this discussion, as you had put it.
Yes. Now, I'm going to shoot straight talk.
Yes.
Over the weekend, there's been so many memes on social media around the project that was launched by the Department of Health in the Eastern Cape. Some people went back to get, pictures of what used to be used as sort of ambulances 100 years ago. And they're actually saying, you know, we are back to the future, you know, with what you guys have put in place. People don't understand, you know, are these ambulances? What are these? You know, so I want you to help us understand, you know, what exactly is the project all about? Because I think as citizens of this country, we want to be able to understand so that we can see the merits. There is currently a negative narrative, especially in the media, social media and print media. So the first question that I'm posing to you, Doc, where did this idea come from?
Thank you very much, colleague. And maybe I appreciate the fact that you are also affording us an opportunity as a department and also as a province, because indeed the miscommunication or the mishap around the project and the launch was not only a provincial matter, but it has since become a national, if not even international issue, seeing how it was covered in terms of the media space. Let me be direct in terms of responding to the question, the first question, because I know you probably have a series of the questions that
Yes, I've got a series of questions.
Yeah, so I'll be specific per question so that we don't spoil the conversation. Where did the idea come from? I think when the MEC took over in terms of the responsibility as a deployee after the national elections last year, amongst the things that she has been consistent in raising as her passion is primary health care. This has not come as a surprise, I must say, because for her, the primary healthcare has been amongst the platforms that she was exposed to, especially when you want to relate her experience and exposure to health as a department. Her previous tenure, she had worked as a councillor and also has spent some time in local government in the main Buffalo City metropolitan municipality, with her major portfolio being that of community health services. So hence her passion and her relationship with primary healthcare. She was there during the time of the AIDS program, which was rolled out at the primary healthcare level. So hence her passion about primary healthcare. Those intentions were made clear by the Honorable MEC when she came in, as she had always mentioned, even in her departmental programs, to say primary healthcare should be the cornerstone, and we should make sure that we make a dent and an impression at the primary healthcare level. Because she's obviously of the belief that once we can get that sorted, we would be able then to sort the other levels of care if we can have everything right at primary. So that's basically background towards her passion. Now, having traveled whilst she was working in a municipality, because amongst her other roles was that of being the chairperson of the Women Caucus of local government and also ultimately of the continent. So apparently when she was then traveling, she then came across this idea, and I think at the time she was traveling in Rwanda, according to her narrative. And when she saw this as a vehicle or a tool in terms of rendering improved healthcare services at primary healthcare level, it's an idea that she had always harbored with her even before she got deployed. So when she was deployed, she then wanted to see how can that fit into the healthcare service delivery of the Eastern Cape. I must say as well that amongst the inquisitive discoveries when she was inquiring about this project in Rwanda, she came back saying that she was also equally surprised and amazed to hear that the production had been from within the Eastern Cape in the form of the Zwelitsha factory. So even then, she was always amazed that we are having people at our backyard who are even supporting other countries and exporting their product, and we have not used it within the country, let alone the province. So that's where the background or the influence came from. It's both in terms of her experience at the primary healthcare. Two, it's her vision of how we are going to improve services at primary healthcare level. Three, it's also that I could say in Xhosa bendizoti, if we were just talking purely Xhosa, benzothi sesasikhwele sentokuba le nto yenziwa apha ekhaya, why can't we then make sure into yokuba nathi we then contribute and make sure that we use and exploit it as we are doing with other programs that are homebrewed. So that's the background influence in terms of the project.
Yes. So, but anyway, as much as you are saying it is her passion, the area of primary healthcare. However, it is actually aligned to the health policy of this country that health must be rooted on primary healthcare, and also with NHI. Primary healthcare is actually the center of what is going to be provided. So her passion is actually aligned, my understanding, to what the country wants to achieve. But also the WHO is also talking the same language, that primary healthcare should be the center of health services of countries. So in a way, it's not a passion that is actually out of place. Would you agree with me?
Yes, and I think maybe let's also acknowledge that sometimes, Doctor, that we would know all these things that are documented, but me and you would know that even just in our own practice as medical doctors, there are so many things that we know to be documented. But as to how we respond, especially when it comes to our own passion about them, our own involvement, even our own sacrifice in terms of how we then apply what we know to be documented, it's something else. Hence, maybe the emphasis for me was to say it has been a passion. Obviously, fortunately, or coincidentally, if others want to make it a coincidence, but fortunately, it also is in line, as you had said, with all the other documents. And also, let's also agree that political heads are deployed by political organizations as well. And she also was sharing that same passion in her own political organization that she comes from, even before she was deployed. So that's why, to me, I'm saying the drive more than anything else, as supported obviously by the documents that you were quoting and the guidelines, but the drive was also the thing, which we must agree that at some stage, even when you deploy people, you hope that they'll be passionate about the work they are doing. So when that comes to the fore, you really do become proud, even if it's not my place to say, but you do feel and see that there is a drive over and above the person just sticking to what they were told or what they were given as a mandate, if I can call it that. But when there is a passion, it also does assist and goes a long way.
Yes. So then she got into the department. This is one of the areas that she thought she needed to roll out, as part of, her strengthening the primary healthcare system. So how long did that process take from the time she said this thing must happen, the procurement and talking to that company and everything, to what we saw last week?
As you might remember, this administration being the 6th administration, it's only last month, that it was actually supposed to be celebrating its first year, if we're counting in terms of years of age.
Yeah.
But obviously, we do know that government, by its nature, is not supposed to be treated as a incidental or eventful tenure. So yes, it's a 6th administration, but their term has been only 1 year. Yes. So as we were saying, that she came with that, having experienced it before she was even deployed into legislature, let alone the department. Yes. And she had shared it. I know she hosted what we referred to as a health summit last year in October. And subsequent to that, that's where she was given an opportunity to say, as departmental officials that have been in the space, including partners in the form of the portfolio committee oversighting, and also the NGOs and the partners that we work with, including the Eastern Cape AIDS Council, ECAC. So in that health summit, that's where she also gave an opportunity for people to say, where do they want to see the Eastern Cape Department of Health going in the 6th administration? And obviously use the platform as well to share that primary healthcare is one of the areas that we should not falter. As much as we would even integrate other health services, but when I'm here, let me declare that my passion and interest is indeed in the primary healthcare system. So that was around October last year, when we were hosting the health summit. Yeah. Subsequent to that, you would remember that the administration, when it came in, they had been already declared or already confirmed programs for the financial year 2019-2020. So in actual fact, when the 6th administration came in, the remainder of 2019 was not actually theirs in terms of the administration. That was from the previous administration. So the processes then had to wait for an opportunity whereby we would then start officially a new term in terms of the financial and the financial year that will be linked to the sixth administration's vision. Hence, it had to wait up until it then went through. We were preparing for our portfolio budget speeches for March before, obviously, the COVID issue. So when Parliament rose this year around February after the State of the Province address, you would see that some of the inputs were coming and were directing that the province is going to strengthen the issues of primary healthcare. So I'm just trying to narrate in terms of the sequence of events. Yes. And then, unfortunately, it was scheduled to be tabled as a budgetary speech item in March, and those that had to be suspended. But when the Parliament finally rose in the virtual form, which was last month, to allow all the MECs to then tender in their budget votes, I must confirm that indeed this issue is appearing as part of the budget speech that was prepared by the MEC and tabled in Parliament for the financial year 2020-2021. If we do want to understand and remind people how the legislative and the parliamentary processes go, the fact that the budget was presented and was accepted in legislature, then by then, it then meant that it then becomes a program that we need to implement and follow up through. So that is the process that has been going on. Remember then, in terms of the procurement processes, the MEC herself as a political head is not directly involved with the processes of the procurement process. However, hers is just to share the vision, give a strategic direction, and then the follow-up is done by administration. I must also accede from what I know from the office, though, is that processes that are meant to be followed in terms of supply chain processes have been duly followed. Hence, the MEC was comfortable to then launch the program because, according to her understanding, that we did not falter supply chain processes. And I think there was even support that was given even by Treasury in terms of ensuring that we do adhere to those processes. So that's how the sequence of events had then since happened. Yes, we do know that the plans and as projected in the budget speech are that we will have 100 of these scooters for a mixture of services. And when we were launching last week, we had on display and for the launch 6 that were there. So because obviously also the supply chain processes will still take a bit of their time, but the MEC then launched because those we had ready so that we can showcase what we meant when we wanted to introduce this service.
So how many are envisaged, for this 2020-2021, financial year?
For the financial year, we want, the MEC is intending that all 100 will be for the financial year 2020-21.
Yeah. And now, just to help us understand, maybe before we get into the next question I was going to ask, for the benefit of people who don't understand what primary healthcare is, can you at least just give us a sense, what is primary healthcare and what is the state of primary healthcare in the Eastern Cape?
Thank you very much. I'm smiling. Yes, okay. That's why I was smiling at the second part of the state, moreover. But just to make people understand as well, is that I think simply put, primary healthcare is just the entry point to all to the healthcare services. And as its name will suggest, primary, it means it should be at the lower level, and it should also be accessible to everyone in terms of when they need any entry to healthcare services. But what people see around as an expression of primary healthcare, in the main, people will see it as clinics. But let's remind people that it's not only the issue of a clinic, especially the physical infrastructure building of clinics. Primary healthcare, by its nature, it's meant to encompass a number of programs that deal primarily with ensuring that we prevent any sicknesses. That's basically what primary healthcare is supposed to be doing, to ensure that people have got a healthy lifestyle, to ensure that people are living a preventative lifestyle, even when it comes to the health interventions. Ideally, primary healthcare wants us to have a preventative health state compared to a curative health state. So it becomes then the cornerstone of our healthcare services in any way. So that's where we want to emphasize to say, let's rather have a tangible impact at that primary healthcare level. Before people then we get to worry about where are they going to sleep in beds, where are they going to get ventilators, where are they going to get ICUs. Our focus should be that let's make a tangible impact at primary healthcare level. Then in terms of the demarcations or in terms of government structures as it is, usually we then primary healthcare would fall under what we refer to as district health services, because by their nature, the delivery should be at a district level, and all the facilities and the programs are run at a district level. So it will fall then under the district health services. And in the Eastern Cape context, then we do have 8 districts around the province. That will be 6 districts and the 2 metropolitans. And out of those, then in terms of the leadership structures, we have then have the district managers being at the level of a general manager, which was also aimed at facilitating and fast-tracking also the service delivery issues, so that we don't always have to wait for the head office when decisions have to be made, hence the general manager level at that platform.
All right. So you've got these 8 districts across the province. And now this is a province that historically has had different parts. You know, some parts belong to what was called the former republic. Some was Ciskei, some was Transkei, and now you've amalgamated all of these. I would guess then that the state of facilities and everything can't be the same across these 8 districts. So where do you think, from a primary healthcare point of view, there's the most need for the type of intervention that you've just introduced last week?
Thank you very much, Dr. N. Indeed, the environment, the landscape, and obviously the service delivery opportunities have never been the same. Fortunately, we also try to say, for the benefit of a democratic state, we should not always be reflecting on the issues of the past. But where we get an opportunity like this is a frank discussion, we would not overlook and remind people that indeed the past has got a role that it has played. Yeah. Whether you talk of the demarcations, you talk of the infrastructure, and you talk of the access, it does have a role that it has played. But nevertheless, when it comes to this program that has been launched, which is indeed going as planned in terms of the MEC's program, the initial stage and intention is aimed at what we would refer to rural communities of the Eastern Cape, which therefore by nature then says, in any case, the Nelson Mandela, for instance, as an example, is not a classified rural district. It's a metropolitan by its nature. So in this round of the hundreds, the MEC's plan was not to involve metropolitans. It was meant to go directly and be specific. Remember, we said earlier on, the idea here is to have an impact that is tangible. If maybe we can just bring your listeners into confidence as to what informs this whole thing in terms of practicality.
Yes.
It is those instances where you would have your healthcare facilities knowing that their population is supposed to be coming to a healthcare center, but because of the realities of how and where they stay, they end up not coming through. It is also incidences where you would see in our healthcare facilities, a client coming in to a facility through or being carried by a wheelbarrow. You would equally have incidences where an ambulance is dispatched to go and attend to an incident. However, it doesn't get to access the actual client because of the environment and the infrastructure. So that's what we are trying to get close to say that where there would have been that patient that ordinarily knows that I can go to a clinic and I think my blood pressure is high, hence I'm having this terrible headache. However, I'm not able to go across and get to the clinic. Now, this is how it's gonna bridge the gap. The alternative is to then say, let's bring down our BP machines, let's bring down, we know our environment. Remember, when we talk of an ideal primary healthcare platform, in our area and village, we should know the disease burden. And also we should be able to get close to a profile, especially of the clients that are utilizing our system. So when I'm going to area X, when I know that in that area, according to our system, I have got 20 hypertensive patients. I've got 13 diabetic patients. So even when I'm packing my trip or packing my stuff to go to that area with my scooter crossing sometimes a narrow bridge that people would not necessarily cross, or sometimes going through bushes to get to that other place, I would have prepared that I'm going to render primary healthcare services. Others can then say, yes, we are trying to bring a clinic closer to where the communities are. So that's how it's meant to assist. And where that person who is rendering the service then discovers that indeed this one patient that I'm attending to is having a shortness of breath, I don't have enough nebulizers with me, this person needs to get close to a facility, fixed facility where they can get this. Then there will be a communication that says, can you please dispatch an ambulance? It can meet me up there when I just get through this bushy area. But this patient will then need this type of an assistance. The ambulance meets us halfway where it would ordinarily park and call and say, I can't get to that house. But now the patient will be brought closer to the ambulance, and from there the patient will get the necessary care that they ought to get. So that's what it's aimed at doing, to bridge the gap and to try and get close to that one patient that ordinarily would not have had a chance if we did not have that service offered to that person. I know at times that people might not necessarily relate, especially when the experience is not there. Others might think we're exaggerating when we talk of patients coming in wheelbarrows. Others might think we're exaggerating when we say other patients end up succumbing because there was no access to a primary health care. But for us, we are of the opinion that should you be able to reach that one person who would have used a wheelbarrow, that one person who would have ended up succumbing at home, yes, indeed, an impact would have been made, an improvement would have been made in terms of the primary healthcare services, and invariably a life would have been saved.
Yes. So are you then saying this is the link between a primary healthcare clinic and the communities, especially those that are not accessible because of road infrastructure and things like that? What's the role of the community health workers in that whole situation? Is it the nurses who will go to the community, or is it the community health workers?
I think that's where the advantage would be, if I can call it that. Currently, we do have these soldiers that are on the ground in the form of the healthcare workers. Yes, we do acknowledge that some of the limitations they have is they would then come to an area and, like I made an example, would still find this patient that is having shortness of breath, and there's nothing else they can offer except to say, Mommy, we are going to call an ambulance for you. Mommy, just we'll go and report to the sister at the clinic that something, or whatever the case might be. But now, if you integrate them with this system, like we said, it will easily be converted to say, ambulance, come and meet us halfway, there and there. We have already picked up this patient. We can even give immediately the vitals thereof because they would have taken all that. And there would be that initial entry in terms of how do we make sure that we render a healthcare service immediately. And by the way, let's also be frank that the innovation of introducing this platform, it should not be seen as just a scooter, but a platform of healthcare service delivery. Yes. And how the innovation is expected to revolve. We should not undermine how some of our healthcare workers across the different categories, including doctors and nurses for that matter, some of them have already been going an extra mile. We know last year that there was a story that we ran where we were acknowledging some sacrifice of doctors around Zitulele Hospital, where at times there would be flooding or there would be a challenge of patients coming across to the hospital. And we've seen doctors, they're saying, no, what? It's better if it's me alone crossing to go and service them that side. So that's how this innovation is going to link, because somehow we are still excited and looking forward to a situation where even our doctors in the hospital will say, we are raising our hands, go and take us through licensing of how to ride these scooters. I would also go and render a service. So now it means you are even bringing a doctor closer to your communities that will even render the first care at that site or at that home. And in actual fact, that's what primary healthcare should be all about in any case, to say that let's bring the healthcare services to the people where they are.
And doing home visits where necessary.
Exactly. I know you are not of my generation, so the generation that was before me, yours and before, you know that when we were at medical school, we were always exposed and taught these things. One, through the clinic committees and the clinic projects that we used to do on Saturdays when we were not at school. We used to go out and render community healthcare workers. Community service. Yes, Rankuwa neridzena, nerialiko Soshanguve, yabo. So that's what we used to do. And even during the clinical studies, when we were introduced to even family medicine, some of us went as far as KwaMhlanga. You had to do a household profile where you then had to say, what are the risks of this family? So that should you be called to say a certain family member, you know exactly what are the. So it's not something new in terms of the healthcare delivery. It's just that previously, maybe one way or the other, the system itself had not allowed us to even practice what we were taught at school. But now when you bring these platforms as an innovation and as an introduction of new things that we can try, like I'm saying, you would find that some doctors will even raise their hands and say, I would love to be part of this. This is what drives my passion. This is what I joined medicine for. So let me be part of it, including nurses as well. That will then say it's no longer only about community healthcare workers, but we are saying this is a platform for us to render a healthcare service for our people.
How safe are these scooter ambulances, though?
I used to envy bikers, but I also am scared because when I grew up, the injuries I used to see from biking would scare me. So I'm trying to just say that obviously, even when we drive cars, there are risks that are part of driving cars. So at the end of the day, any mode or form of transportation would always carry its own risk. It's something that all of us we must agree. But let's also be cautious that as a department, we are not just gonna jump into this and not look into how safe and how best can we make it. As a result, let's just also assure people that even in terms of these ones that we are gonna be releasing in the first batch, there has been an arrangement to say, one, let's ensure that you don't come and say, I can ride a scooter because you could ride a mountain bike. Those are not the same. You see? So we would still ensure that people are certified or have been licensed to do that work. Hence, I was saying that in the future, we are hoping that even some other healthcare workers would then raise their hands and say, guys, I'm also availing myself. The department can send me for the licensing and the training so that I can be a part of this program. And yes, we would always make sure that there is safety that is being followed. And obviously, like any other area of mode of transport, where the worst can happen that would have incidences, obviously, we are not going to be dogmatic and say continue when we can see there are risks that have been incurred. There would always be room to say, now that we have tried this, how are people feeling? How is it impacting? What are your areas of concern? And including risks that you have picked up. Because obviously we can list any risk that we think now, but the only time we'll see how impactful they are is when we are out in the field anyway.
So now early today, after I had read an article, from the department, your department, trying to explain that you are bringing healthcare closer to people and understanding the issues, of deep rural Eastern Cape, I could see where these things fit in. However, my friends on Facebook were just not understanding why I'm supporting this thing. They were asking who in 2020, would go for scooter ambulances and not look at things like airlifting of people and all of that. And my arguments, they were like, not everything is like a critical emergency. There is room for this thing. So what do you want to say when people say, why don't you just focus on improving the clinics, improving the hospitals, and having, airlifting instead of, getting scooters that were used 100 years ago?
Maybe let's just remind people that what we have introduced and said we are bringing in a mixture of platforms for us to render a service.
Yes.
Remember, even in terms of the clinic, taking clinics alone in terms of PHC, you would have a fixed clinic. Yes. You would have a mobile clinic.
Yes.
Even at the time when mobile clinics were introduced, other people said, we want a physical structure and we want a clinic in our village, a clinic in our township.
Yeah.
But because we needed to bring a different platform and a different mixture to respond to the need of rendering a service, mobile clinics were introduced. And guess what? Other people now will tell you, when that mobile clinic has got a breakdown and doesn't come that one day, they feel the impact of it. And they would then call to say, can you ensure that our mobile clinic is back next week? You see,
Yeah.
so at first, when you introduce different things, obviously there would be a concern, or maybe I'm just thinking of a Xhosa word which is nice. We are bringing things that people are not used to.
Noise.
And that's how we are taking it. Yes. I wanted to be polite. Hence I said, and Funabantu Batindi depends the noise up. They might miscrew it. Yeah. So there would always be that. We are very mindful of that. And we appreciate even the platform you are giving us to say, let's have a conversation. Let's not just write one lines in Facebook to just try and just let's have a conversation which will make sense to people. And we want to thank you for availing this platform to us, and even other people that are giving us a chance to explain. And what we're trying to do is that at the end of the day, all the different platforms that are there when it comes to health delivery have got their own niche or own targets.
Yes.
It's like we would not have every town having a central hospital, because by its nature, it's got super specialties.
Yes.
In Eastern Cape currently, officially, we've got only one central hospital, which is the Nelson Mandela Academic Hospital in Umtata. That is what is gazetted. So we cannot have other people saying that, but we also want a central hospital and whatever. But it's how the public health system works and how it flows. That would have different platforms, and different platforms will have a different niche. And what we are saying is that currently we are looking at a primary healthcare platform. And what we have discovered is that the current platforms that we are giving, which is in the main your physical clinic, your mobile clinic, and even the CCMDD platforms, we are saying they might not also respond to everything that is there and make a difference and an impact that we want. And like I say, when this argument came over the weekend, a few of the discussions I had, people will narrate that, no, but scooter is backwards. Now imagine that mama there, now it will be bumpy. And I would then say, can you conclude that scenario? Currently, what happens to that mama? Because that's what we want to respond to. And if your scenario is saying currently that mama ends up using a wheelbarrow, would you say a wheelbarrow is still better off than what we are offering? If you then say currently that mama ends up not even going anywhere near a health facility because there's no means, would you say then bringing this closer to her is still worse off than what the current situation is? So I think now what I would like to plead to people to say, yes, maybe when it just appeared in your face, it might have shocked you or it might have surprised you, but also now that we have been having platforms to explain to you what is it that we want to achieve, maybe we could ask that, give us a chance, but also importantly, so you may share how we can then improve it, but understanding what we want to achieve, because now people miss what we want to do, and as a result, they were not even bringing solutions. Like you're saying, the other solution from people will then say, why don't do airlifting? Those who might know the incident that took place last year at Tsendani of a bus accident. We did have choppers that were there. We had ambulances that were there. But we must give credit where it's due. We were helped by a group of young people who are local residents, who were running up and down that hill to go and help us pick up patients, because even though we had all those resources there, the landscape just didn't allow them for us to be able to intervene. So there will be areas where these airlifting ambulances are not ideal, but we are of the opinion that the scooter might make a difference, and it will close a gap when we do get that chance of having those incidences.
Yeah. Okay. So I can see, where all of this is going. Now, in trying to understand what you guys are coming up with, I picked up that in Uganda, Eastern Uganda, there's some NGO from Wales that actually donated exactly the same type of, scooter ambulances And there, people are so happy to have them. They feel it has bridged, a gap in their healthcare market or healthcare delivery. Also in Sudan, the same thing. There's a good reception, but other people say, no, we are South Africa. We shouldn't be aspiring to deliver services like Uganda and Sudan. And UNICEF has actually applauded countries that have put this in place. UNICEF says this is a vital EMS service, in developing countries. So South Africa is not, is actually following on other countries. And in those countries where they've, put this in place, they are actually reporting that deaths from pregnant women, maternal mortality rate has actually gone down. And even those infants who had health challenges, it has gone down, what we call infant mortality rate. So in other countries, UNICEF, being a global body under WHO, has actually said, you know what, this thing does work. So now, if you look at the cost now, let's talk cost. We are told that each of these costs just about 94,000, with maintenance another 6,000. So it's about 100,000 per unit with maintenance over 3 years. 10 million rands contract. Do you think this is money well spent?
Thank you very much on our costing. My exposure and teaching when I was going studying MBA. In medical school now we are deprived of economics and anything that deals with money. We just want to give people drugs and that's it.
Yeah.
One of the things I appreciated was that module that was talking into economics.
Yes.
And there was one element that I personally felt that I needed to hear, and it was a good timing: the issue of opportunity costs.
Yes.
You see, there they talk about saying, how much will it cost you should you not have done something?
Yeah.
And I think that's what everyone needs to understand in terms of the healthcare delivery.
Yeah.
That if I don't respond to a call when I'm on call and someone dies, you see now, I would argue that no, I still want my call hours to be paid according to what rate, but what did it cost when I did not respond?
Yeah.
So it's the same thing that we want to raise to our citizens, to say that at this stage, we are more than convinced through the MEC's intervention that we are not at a stage where we are able to even say, no, Gogo, you belong to that wheelbarrow. And we are not, as a caring state, prepared to spend on you. And that's how we have looked at it, to say it is an intervention that we feel it is worthy to go into an expense of.
Yeah.
And like I've said, in that one trip of a healthcare worker going across that bush area to service a population that would ordinarily not have been serviced, that is another a benefit in terms of benefit analysis.
Yeah.
We were doing the outreach programs where we would just go and bring services to rural areas and needy areas. We go there knowing that these people have got a clinic that is fixed, that is so many kilometers away because of how we found the system. 2, we know that we are giving them mobile clinic that comes every second week. But the excitement, the appreciation, the relief, the pleasure, the joy that you see from that community when you are there for 2 days, rendering a community outreach, to me, that is what any other caring government and healthcare system should be able to bring to people.
Yeah.
So for us, we are convinced that when that mama that ordinarily would have just been indoors in that house, then gets that knock from a healthcare practitioner that says, I came through, I crossed through this bush area, I am from that clinic, and our records are showing that you have not been to the clinic for the last 3 months, you have not collected medication, we have been wondering what's happening with you. and that mama is saying, I have been in this bed, I've been wanting to come, and I've not been having means to come to the clinic. To us, that is what is worth it to spend on.
Yes. Okay. So I heard you earlier talking about CCMD program. For those who don't understand, what is this CCMD program where you think these could also be useful?
Remember the NHI re-engineering, primary re-engineering also has got different parameters. I'm sure we will still come back and have a conversation about how we have been doing in terms of the NHI project going forward.
Yes.
I know you have said we'll be 30 to 45. I am on call tonight.
Oh, yeah. No.
So I don't mean to rush out. Yeah. I mean to rush our conversation, but I think when we've got time, we would talk about.
So just one sentence about what it is.
So the CCMD program was aimed at trying to, one, ensure that our patients that are on chronic medication stable receive their medication on time. Two, it was aimed at making sure that we decongest our healthcare facilities. Because people who use a clinic would notice that most of the time you would have people that are saying, I'm coming to collect my medication. Yes. And those people will be filling up our clinics. So CCMD was trying to say, yes, mommy, daddy, you want to come and collect your medication. However, let's bring the medication closer to you. And how the program was designed, it was even saying, we don't have even be the ones to decide where you get your medication. We would look around areas that are close. We even extended invitations to church institutions, extended invitations even to local shops that are close by, that are busy in a certain village. So that's why it is about say those people that are on chronic medication, controlled chronic medication, because also we don't want people to say, what will happen to my grandmother when she doesn't come to a clinic for 3 months or whatever. No. It's people that are controlled, and there are schedules that are given even to them to say, after this duration, you must then come back for us to review if indeed the medication is still treating you well. So that's why we're saying that even those that are defaulting on that CCMD, when we go out on our scooter programs, we would be able to say, this is our records. We had put you on a CCMD program. However, we've been getting a report that your medication is bouncing, you're not collecting it, or what is happening. And then we'll be able to close that gap and make sure that services do get to those people.
Yes. So as we wrap up our interview, I'm almost a few minutes over what I had asked.
It's understandable.
Yeah, what message do you want to say or give to South Africans who were quite, obviously, confused about this whole thing? So what message do you want to give to them so that at least they are able to give you guys a chance to actually show that this was actually something that is adding value?
One is to remind people that, as we spoke earlier on, primary healthcare services is a mixture of platforms. It is not just a clinic. It includes promoting healthy lifestyles, where you would even have your health promoters coming to talk about healthy lifestyles. It includes ensuring that people stay as far away as they can from being ill or from our facilities. And this gesture or this innovation and innovation from as led by the MEC Mamukomba is aimed at saying, what mixtures can we avail at strengthening or at primary healthcare level to strengthen the service that we are rendering to our people? And we would like to plead with people that give us whatever options or opportunities or even ideas that you have to join and add into the mixture. But as it is now, there has been a conviction that this introduction of the scooters as part of mixture of the platforms that we are going to use to render primary healthcare level will also benefit our people. And we would like people to support it. We would like people to, even if you might not have had an experience before, but just think of the scenarios that we have also shared with you in terms of now, if we take away this opportunity to help those people, would we not be sending a wrong message as a caring country or as a caring government? That when this one time they felt that at least our needs were met, because since they sang with Facebook and with social media, now that will be taken away from them just because we don't understand their plight or we don't share their plight. It would be unfair. And I think that this creates an opportunity for us. And maybe another opportunity that it has presented itself is we probably as a country don't always go deep into discussing and having a conversation about the societal impacts of the healthcare services. Because this is the reality of the matter. We've got issues that affect healthcare service delivery, and other people might not be exposed to them. There are people that have never seen a gravel road or never had to go through a gravel road, let alone having to go through a river to get to a healthcare facility. So those are societal issues that do impact how we render healthcare services, and would invite people to just bring ideas and maybe come through and see what are these some of these environmental and societal issues that we are referring to when we talk about the healthcare system of the Eastern Cape.
Yeah. All right. So would you, because somebody else also talked about, if you put my mother on that thing, where is the dignity? So do you think there's any dignity in people being put on those scooter, ambulances?
That's, like I said, if currently he's using a wheelbarrow to transport the mother, would it exempt the question of dignity?
Yeah.
Compared to a health service platform that is being rendered, because it's a platform. As we are busy transporting the mother, there is a health eye, there is a healthcare worker mind, there is a healthcare worker intervention that is being there, compared to me just pushing my mother on a wheelbarrow.
Yeah.
So the issue of dignity, is it's fine if I'm taking away dignity of my mother as the son, and it's not fine when I perceive the Department of Health to be taking away the dignity of my mother. So that's why I'm saying it has also brought in an opportunity for us to discuss societal issues. That kahle kahle kwathina, are we still caring for our mothers, or sibakhumbule ngoku ngosuke kubekho into ku Facebook?
Others are saying, others are saying by allowing programs like these ones, which are actually addressing inefficiencies of government, in general. So we are actually delaying the resolution of those problems. So they're saying, why don't you fix the roads so that you don't need to have scooters? So it's a chicken and egg situation. Fix the roads, or get the scooters, and delay fixing the roads.
And for us, it's a question of course, we would love to have roads. We would still want an ambulance to reach every household. But equally, us being passionate about rendering healthcare service, should we be crucified?
Yeah.
Because that's another way to look at it.
Yes.
Because we could be like them and say, let's join you in singing that there must be a road there.
Yeah.
And at the end of the day, the healthcare service is not being rendered.
Yeah.
So that's why we're saying that it has sparked a interesting debate, and I'm hoping that the society will still take these debates further, so that at the end of the day, people will understand. Last year when we were preparing for an outreach program at Alfred Nzo in Bizana, we had to go and meet the MEC, had to go and meet one of the chiefs. On our way to that kingdom, the scenes there that you would see of some villages, it was really heartening to see that, and we kept on asking ourselves to say, are we really servicing these people? You see, and the other twist to it, we were saying, maybe indeed our technology innovations should not be restricted only to our urban areas. Because at the end of the day, we've got people that we still need to service. I looked down at some of those areas and I was like, I am imagining now when that person calls at 10 p.m., finally succeeds to get through to EMS and reports this patient, and EMS tries to come close. It's 10 p.m. at night. And how do they get to that household down there? So there are those realities in the Eastern Cape. And I must say, I am from the western region of the Eastern Cape, and I got to be exposed to the realities of Eastern Cape when I joined the circumcision program in 2014.
Yeah.
And I know for a fact that there are those people that are like me from Etinaga who unfortunately has never come out of Western region. who would not be able to relate to what we see out there, who would not understand the need, who would not understand the pain, who would not understand the frustration that other people are experiencing out there. So mine is to say, as a society, those are the issues that we probably need to be discussing. To say that, how far are we? Would we ever get to an equal society? And if we don't, how do we assist the society that is deemed as not equal to the other? And make sure that at least they still get a service that they deserve as human beings as well.
Yeah. Doc, I think on that note, let's wrap our discussion. Thank you very much for availing yourself, even though you are on call. I think it was important that we get a voice from the office of the MEC, and you being the special advisor to the MEC. I think we've been able to get the thinking behind the project, and all that we have to do now is to then obviously monitor and see what impact this intervention has brought, and where you've got good stories to tell, please share with the nation, so that maybe through action and less by what you guys say, people can be convinced that this was a timely and appropriate intervention for unique circumstances in those underdeveloped parts of your province. So I want to thank you for your time, and thank you to the spokesperson as well who arranged that I talk to you today. And with that, I want to thank you again, and I want to thank our viewers for logging on for the almost 60 minutes of us talking.
No, let's thank you for really arranging this platform for us, and indeed it has been an intriguing opportunity and discussion for us. And I must say that viewers also have also shown an interest. I've also tried to stream live on my Facebook, and people have indicated that indeed we needed to have such a conversation. And let's thank you for thinking of us as a province and allowing us an opportunity to also try and put it's not even to say our side, but to put the intention out there. As to people whether we'll decide whether it's a side against a side, then it will be up to them. But thank you very much, and thank you as well to your listeners. And like we said, as an Eastern Cape, we really appreciate this platform, and they would be more than welcome and willing to participate even in future endeavors to try and make sure that we have a conversations of this nature.
Yes. Thank you very much, Dr. Bayeni, and thank you to our viewers. With that, we are now wrapping up the show. Siyabulela kuninonke, and till next time.